Well, good evening. Good evening. I am so sorry I'm late. I was having some technical difficulties. I was going to try to use StreamYard, but for some reason my StreamYard app got deleted. Well, I know why it got deleted because I deleted it, but I can't add it back, and I'm frustrated with that. So I am a couple minutes late, and if you've been around me for any period of time, you know I really do not like to be late. That is one of the things. I was in boarding school. I don't know if you guys know this or not, but I was in boarding school in South Africa, and our headmistress had a saying that if you're not 5 minutes early, you're late. So I detest being late, and today I am 3 minutes late, and I don't like that. So I apologize because I value your time and I don't want to waste your time, so I do apologize for being late. Thank you for coming. Tonight is Dementia Made Simple. I don't know how many episodes I've done on these. Hey, we're getting there, Russ. We're getting there. We're about 53 short, so we will eventually get to 500. That is my goal. My goal for the end of July for myself was to try to see if we got to 500 people in this group. I'm a little short, but you know what? It's a goal. I don't meet goals every single day of my life. I don't know. Most of us don't meet all of our goals every single day of our life. So today I thought we would talk about, last week we were talking about the functional assessment staging tool. So the functional assessment staging tool is it's a model called, that's a retrogenesis model. A retrogenesis means back to the beginning. Okay, so back to the beginning. In our world, I'm an occupational therapist. In my world, we have an additional tool, which is called the Allen Cognitive Disabilities Model. And the Allen Cognitive Disabilities Model is probably the thing that I use the most every single day of my life when I'm working with people with dementia, because it is a tool that gives us that's very functional, and it really works on what's known as retained abilities, right? So often in this world with people with dementia, we are only focusing on what they're not able to do. But at every stage of dementia, people are still able to do things for themselves. And those are what we call the retained abilities. Granted, they may not be able to pay their bills or do their medication management, but they may be able to do other things. And we want to make sure that we are tapping into their retained abilities and not just looking at this as a disability, right? As something that we cannot change. There are things that we can do. We can change the task, what we're doing. We can change the environment to make it easier, and we can change how we approach the person, how we talk to them, how we cue them, how we do all these different things. And when you get all of those things together in the right way, you are able to elicit the best response you can from somebody who has dementia. So the Allen Cognitive Disabilities Model, what they did is they made an additional staging tool called the Adapted FAST, or the Adapted Functional Assessment Staging Tool. And I'm going to quickly go through it tonight because I really think that it is truly valuable. It really helps when we focus on ability instead of disability. It really does help be able to engage people that we care about who have dementia or cognitive impairment, engage them in their life still. And that's certainly what we want, right? We want everybody to be as independent as they can. We don't want people to just be left in bed or just forgotten. I'll use a quick little story before I get into this. Interestingly enough, I still practice as an occupational therapist. I work in home health, and I have a patient right now who has a phenomenal family. Totally one of the best families I've ever worked with. Almost everything I've recommended, they've kind of implemented and tried to do. But she's pretty far along in the stages of dementia. And so according to the Allen Cognitive Disabilities Model, one of the staging places that we look at is if somebody is able to hold and recognize what a tool is. this is a pen. Let's pick the red one, Lizette, because it shows up better. This is a pen. If I give it, I'm the patient. If I give it to my patient and they hold it and they know what it would do, even if they can't write anymore, but they would turn it in the right way. Or I don't have anything other than a pen up here that's handy, but imagine this was a spoon, right? If you give them the spoon and they take it and they know how to use the spoon, that puts them at a certain level according to the Allen Cognitive Disabilities model. What's interesting, when I look at her, when I look at this particular patient, I actually think that she's a little lower than that, but functionally she can still feed herself, and that was one of the things that her family wanted her to be able to do. But what's certainly been interesting with her is she was on hospice, and they took her off of hospice, not they, the family, but hospice took her off of hospice because she's actually doing pretty well. And so what's happened is, because she was on hospice for 6 months and had been laying in bed, and they hadn't really been getting her up because she's on hospice, when we started to come in for occupational therapy and physical therapy, I had a long conversation with my physical therapist, who we work with really well together, and I'm like, hey, while I work on these things, will you just work on setting her up on the edge of the bed and seeing if we can get her up against gravity again, because she's not been up against gravity. And so today I go to the patient's house, and her family had actually carried her, she can't walk anymore, actually carried her to the bathroom, but she's holding herself upright on the toilet. And so, hey, Kathy, so I'm like, okay, so you're holding yourself upright on the toilet. Maybe if I keep going, because we're getting ready to discharge her, maybe if I keep going, functionally she'll have some more retained abilities. So even though she really looks, according to a lot of the scales, that like the functional assessment staging tool and some of these other staging tools, she looks like she is end-stage dementia. And I'm not saying that she doesn't have end-stage dementia, but she still has some retained abilities. So I made a deal with the family, and I told them, I said, I will make you a deal. I will keep working with her if you do the following things. Get a bedside commode from a family member has a bedside commode. Get a bedside commode every time because she's now asking to go to the bathroom, so she's recognizing she has a need to pee, and she asked them to put her on the toilet. So I'm like, get a bedside commode, put her on the toilet, because they always have two people. Put her on the toilet every time she wants to go, and get her up out of bed every day. If you do that for a week, and you show me that you're going to do that, I'll keep going with her. I'll keep working with her 1 time a week until I can see if I can stand her up. And if I can stand her up, then I'll ask for physical therapy to come back in again. So just because the staging tool says a person's at a specific level doesn't necessarily mean that they don't necessarily have retained abilities. So this particular patient is showing me that she has some retained abilities, because she's actually now speaking more, because they're interacting with her more. Not that they weren't interacting with her, but they're getting her into not the dining room, but the TV room. They're setting her up. She's speaking in a few sentences. She's doing some things that lead me now to conclude that even though she is definitely at the end stage of her dementia journey, she's not as far along as I had thought she was. And that's why I like the functional assessment staging tool that was adapted by the occupational therapists that are brilliant observers of people, because it goes more into function, right? So a staging tool can give you a down and dirty. It can say, you're kind of looking like this, or you kind of look like this, or you're not quite as far along as some of the other people, but it doesn't really show us what a person's still able to do. And so my homework for everybody is to always try to see what the person is able to do for themselves. We always want to try to elicit that independence as best we can, so that we can keep working with people and give them their best quality of life, right? Because that's ultimately what it's about. Ultimately, we're all going to pass away. Ultimately, we're all going to die. People who have dementia typically have, we know that it is a terminal process that could be anywhere from 2 years to 20 years or 30 years. People are amazing. People are amazing. Just because a person has like an end-stage diagnosis of, say, some sort of a cancer, and the doctor may tell you, oh, you've only got 6 months to live. Well, I've met people who the doctor said, you've only got 6 months to live with a terminal cancer diagnosis that have been alive for 5 more years. My brother-in-law is one of them. And so just because we know that this is a relatively predictable outcome doesn't mean that we just say up and say, oops, there's nothing that we can do. There's a lot we can do. We want to engage people in their world. We want to bring them into as remaining as independent as they possibly can. We don't want to just say, oh, well, you've got dementia and therefore, right? So let's talk about the functional assessment staging tool, the adapted functional assessment staging tool that was adapted by occupational therapists. So the first stage, obviously, of the functional assessment staging tool is a person that has no trouble. Normal people, well, I will contend all normal people have trouble with their thinking. I'm not a very popular person when I say that, and I say that about myself. I have days when I'm not thinking clearly as well, when I'm tired, when I'm hungry, etc., right? We all sick. We all are. Cognition is not static, right? So our cognition doesn't stay, boom, this is our cognition. Everybody has a normal range, and we go up and down. We go up and down through our normal range. So stage 1 is no objective or subjective functional changes. Then stage 2 is a person will subjectively start, which subjectively just means that I feel like they're starting to have trouble in recalling names, other word finding trouble, or subjective difficulties in recalling location of objects, or decreased ability to recall an appointment, no objective functional deficits. So these people, so with these descriptors, these are people with the functional assessment staging tool that are just starting to show that they are having trouble. And this is when maybe the first time when some objective tests, the person will tell you, I can't find my words, I can't locate items, I'm starting to have trouble at work, it's impacting my ability to do my work, but not necessarily when we start to take a test, it's not necessarily going to show. And so this is probably the stage when people is what's known as the subjective cognitive impairment. So I know I'm having trouble, but nobody else knows I'm having trouble. And I will use myself as an example. About a year and a half ago, right before my daughter, our oldest daughter is about 24, she got married in December of 2019. And I was extremely stressed. I wasn't eating well. I was not exercising. I was extremely stressed, extremely stressed. And my cognition went to heck in a handbasket, and I knew it. Nobody else knew it, but I knew it. I knew that I wasn't thinking clearly anymore. I knew that I wasn't working at the highest level that I am able to work. So even though if I were to do a cognitive test at that time, it probably wouldn't show anything major that I need to be concerned about. I knew it. So when people have subjective cognitive complaints, we need to take it seriously, because that is actually the first stage, or can be if you don't change things in your life, which I worked on losing weight, I worked on eating properly, I'm on a keto diet. I haven't been super good right now because my husband's not here. I don't cook for my kids, I don't cook for myself, I cook for my husband. And so I'm not doing as well as I had been about 6 months ago before he started staying up in Greenville working on our duplex. But subjectively, I don't have that same impairment that I had about a year and a half ago. Alcohol, sleep, diet, exercise, sleep, and stress. And I had a bunch of those things all going on. My parents are habitual drinkers, and when I'd go visit them, I would start to drink more wine, and I started to realize it's just kind of creeping up on me. And I'm like, no, you got to stop this. Wine is terrible for your brain. Alcohol is terrible for your brain. I'm not saying I still drink wine. I still drink, I don't drink beer, but I still drink wine. But I try to make sure that I'm moderating it, right? But that's what we call subjective cognitive impairment. So I knew I was having trouble, but nobody else would know. So then the next stage, so we're still talking about the functional assessment staging tool, but we're using the adapted one that has the behavioral characteristics that go along with what we discussed last week. So stage 3, this is where it's probably known in the literature as mild cognitive impairment. So mild cognitive impairment isn't mild. It's a misnomer. It very much impacts people's lives. But mild cognitive impairment is the first place where when a person takes a standardized test of some sort on a computer, or a test that I would do, or something along those lines, this is the first time that a test will actually start to show that somebody is having trouble with their thinking. And it's called mild cognitive impairment because it's not dementia yet. Statistically, 20% of people will convert from a mild cognitive impairment to a mild dementia every year. So it does, if you don't change things, if you have been diagnosed with a mild cognitive impairment and you're not actively working on things to change things, to prevent your cognition from declining, it will get worse over time. Unfortunately, in the medical vernacular right now, there's this belief that, oh, I've got cognitive impairment, there's nothing I can do. I've got dementia, there's nothing I can do. Yes, it is something that medically right now has a fairly predictable path, but no, it's not that you can't do things. The earlier you start, which is why I started a year and a half ago, right? The earlier you start to maximize things to keep your cognition sharp, the better it will stay, the better it will remain. There is a lot of research that if you optimize all of the factors, and not just the one factor, but if you actually optimize everything, that you can prevent and improve your thinking processes. And I'd encourage you, if you're interested in that, to read Dr. Dale Bredesen's book, The End of Alzheimer's. It's very rigorous. It's not easy, but you know what? Neither is dementia. So even though it's rigorous, I would strongly encourage you, if you're interested, I can kind of talk to you about it a little bit more, but there are things that we can do. So on a stage 3, deficits that are noted are in demanding occupational and social settings, right? This is where we start to see, at a mild cognitive impairment, this is where we start to see some social deficits, some social interaction problems, right? For example, the individual may start to forget their appointments for the first time. They may not be able to maintain their work productivity. They will start to have trouble moving from familiar to unfamiliar surroundings, so they may get lost when they're driving, right? They may get lost when they go to a public, when they're needing to use public transportation. So mild cognitive impairment isn't just mild. It absolutely impacts people. And if you listen to those three things, the few things, forgetting appointments, starting to have difficulty with productivity at work, and difficulty traveling to unfamiliar surroundings or unfamiliar locations, all of those things fall in the purview of what we've talked about before, which are the executive functions, right? Those higher level skills that we all have, time management, emotional regulation. This is why people who are starting to go through a dementia process, why they get so emotional, because they lose their inhibition switch. So everybody has an inhibition switch. Normal people have inhibition switches. Most people can control their inhibition switch, right? A little kid who's 2 or 3 or 4 or 5 or 6 years old hasn't developed their inhibition switch yet. And so when people struggle to, one of the executive functions is emotional regulation. It's that inhibition switch, right? And so, for example, most of the time my inhibition switch works pretty good, but not all the time. And we all think things, right, that we don't say. We think things all the time. If we're honest with ourselves, we're not nice people. None of us are nice. We think nasty things about people. We think nasty things about people we like. We think nasty things about people we love. We don't always paint them in a good light, right? But we don't always say that. We don't always say to our spouses, you really hacked me off when you did this. You just kind of let love cover a multitude of evils. But think about a kid, right, who's not developed their inhibition switch yet. Emotional regulation is your inhibition switch. They're the one that goes to the store with you, and they're walking, and they pull on your pants, and they say, Mommy, 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 look at that fat lady over there. Okay? When people start to have mild cognitive impairment, their inhibition switch goes, which starts to impact social settings, right? Friends, family. You can't just say what you think, people, because it doesn't always work well, right? Work relationships, productivity. Productivity is planning, organization, all of these higher level skills that you need to be able to have in order to plan and do your job. And then traveling, right? Traveling is very, very complex. Like if you have to plan out, I'm going to get in the car, I'm going to take this route to this particular store. There's a lot that goes into driving. Or you're used to just driving a certain road, and then all of a sudden they put a detour up, but the detour is not marked very well, and you turn down a different road that you're not used to driving down, and all of a sudden you're turned around and you get lost. So that's at stage 3. So these are the functional things that go along with these stages, right? So the stage 4, which is early or mild dementia, early dementia, deficits start to occur in what we call complex tasks of daily living, or the instrumental, I've used this word before, instrumental activities of daily living. So the complex daily living tasks, things like paying bills, balancing a checkbook, decreased planning or preparing a meal, being able to use the stove or the oven, decreased ability to go grocery shopping, unable to manage change when you go grocery shopping, unable to plan ahead what a good meal would look like, right? Not getting your medications filled in time because you just don't anticipate the secondary consequences of something. Other things like being able to plan or structure your day adequately so that you're not just sitting and not doing things. These are all the higher level basic ADL and instrumental ADL skills. And people who are starting to have mild dementia don't always follow the rules of the road. I know I'm not popular when I say this, but driving is a privilege. It is not a right. We do not have the right to drive a car. It is a privilege. We are given, we have to take a driver's test, right? It's a test thing. There's a particular reason why a 7-year-old child doesn't drive a car. A 7-year-old child hasn't developed their secondary consequences, anticipating secondary consequences. Well, when people start to go through their processes with dementia, they start to lose their problem. They start to develop difficulty with anticipating secondary consequences of their actions, and they have a hard time judging distance. And so when you have speed and distance and somebody who is not anticipating secondary consequences, and this is the mistake that most people with dementia and cognitive impairment always make, is they will make, in the United States, we drive on the right-hand side of the road. I had to look out the window to remember because I am from South Africa and I'm used to driving on both sides of the road. But they will cross the traffic. So in the United States, they'll be in the right-hand lane. Somebody's coming from the front on the left, and they'll turn left right in front of that person and cause an accident. So people at this early stage dementia or early level 4, stage 4, start to have difficulty with being able to engage themselves in they're still at this stage able to engage themselves in very familiar recreational activities, and their basic activities of daily living. What are the basic activities of daily living? Being able to get dressed, being able to go to the toilet, being able to feed yourself, not prepare food. Prepare food is a higher level IADL. Get dressed, go to the bathroom, shower, put shoes and socks on, brush their teeth, comb their hair. They can sequence themselves through those very familiar activities and very familiar leisure activities that they always did, maybe Sudoku or a puzzle or something that they repetitively did. So at a stage 5, which is also an early stage dementia, but starting to go towards the middle stages of dementia, at a stage 5, a person will start to have difficulty in picking out their clothing, proper clothing for the day, right? And so we don't think about it, but there goes a lot into deciding what to wear every day. You got to know what the season is outside. You've got to know what the occasion is. And so people will start to have difficulty choosing the right clothing for the right occurrence, right? So they won't necessarily pick out the right clothing. They'll think it's raining outside, and they won't wear clothes that are appropriate to go out in the rain or the snow, or those kinds of things. So they can still get dressed, but they need assistance in picking out what to wear, and they will need 100% help in community functioning. These are things like getting to appointments. These are things like helping them plan out their activity, that they've got a doctor's appointment. They may need help with those kinds of things. So at this level, at an early stage 5, a person or a spouse or a care provider or a care partner has to help the person pick their clothing appropriate for the season, or the individual will wear things that don't match together. And most of the time over the stage, people will start to forget to take a bath, right? They can still bathe themselves physically, mechanically, right? To wash your face, wash your arms. They're physically able to do it, but they'll forget that they've taken a bath. These are the people that say, but I've taken a shower. What do you mean I haven't taken a shower? I did. I told you I took a shower. And you can see they're still wearing the same clothes from 3 days ago when you came to see them the last time. But arguing with them is not going to make a difference, right? They will need assistance to locate unfamiliar rooms and locations in unfamiliar settings. So when people are in an unfamiliar setting and environment, this is where they'll initially need a little bit more help. But people at this level can still learn highly valued information. If they want to learn at a certain stage of dementia, if the person with dementia wants to learn the information, they will learn it. If they don't value the information, you can't teach it to them. They have to want to know the information. And if they do, then you can still teach them. The person will need to help people with repetitive training over and over and over again. We have to do the same thing over and over again. When I work with students, this is one of the things I always tell them. They change things up every session. Like when I work with people with mid-stage dementia, a lot of my sessions look exactly the same, in and out, because I'm trying to do repetitive training. I'm trying to make sure that the person learns something by me teaching it over and over and over and over again. So repetitive activities is more boring for me than it is for the person who has trouble. It's the way that they can. It's the way that they can still be able to engage in their environment and be able to do things. So repetitive learning is very important for people at a mid-stage of dementia. They can still learn, they just have to want to learn it. And they can engage themselves in highly familiar recreational activities, but they have to have these things set out for them. They won't go and initiate, my living room is right over there, so they won't go and initiate taking something out and putting it on the table and setting it out and doing it. That takes forethought and planning and organizing, right? But if you give them the stuff and it's a very familiar activity, for example, somebody who always sewed, maybe giving them something that was an easier sewing task, not a highly complex. I'm, making lace for a wedding dress, but I'm making a pot holder with big loops, right? So there are ways that we can make activities easier for them, but it has to be something that they have always done. Now's not the time to learn a new hobby, And I struggle with this as a therapist because there's some tremendously valuable electronic tools, games, and things that can work on people's thinking. But if a person has never used a computer or even a smartphone or a touch screen of some sort, there's no tactile. There's nothing. It feels the same, right? It's not got buttons like old-timey phones. Do you guys remember the old-timey button phones that you could feel? And what did they do every time you push the button? It made a different tone, right? So there was touch that we could use and things like that for certain activities. So I do use electronics with my patients, but I have to be careful because not everybody can do it. And usually in that case, they may need a care person to be with them, to sit there with them and help them when they get stuck on the computer or the tablet. And they will still have only fair quality. They don't necessarily at a stage 5 have good quality. People don't have really good quality in bathing anymore. They don't have good quality in brushing their teeth or combing their hair. They may see the front, but they don't, comb the back or take care of making sure that there are no rat's nests in the back there. So it is stage 6. So when we start to get into the stage 6, this is where things are starting to become moderate to severe, right, or middle to late. And this staging tool talks about a middle stage, late stage, and then end stage. So they actually break it up. The functional assessment staging tool is actually in 7 stages, and this one is in 8. And so they at a stage 6. When we use the adapted one, which is more a functional occupational therapy tool, the person will start to actually require physical assistance in putting on their clothes. So what that means is we need to start to say, here, put your arm in this sleeve. Here, put your arm in that sleeve. How about we put it over your head? So a way to do it is you can lay things out or just give the person one item at a time, right? When I'm independently doing it, I can walk to the closet, pick out my clothes, put them on the bed, and then sequence myself through it, right? At this stage, at the middle stage, the person cannot put their clothes on without you telling them, put your bra on, fasten it behind you, fasten it in front, turn it around, put your one arm in, put your other arm in, pull it down, put your one arm in, put your other arm in, put your head over, here your panties, turn the right way around, put your leg in, put your other leg in, pull them up. They may need that level of cueing in how to actually get dressed. They mean functionally, this is where people start needing help with tying their shoelaces, putting on their shoes, putting their shoes on the right foot, right? Little kids, when they're little, they don't know left and right, and so they put the wrong shoe on the wrong foot. They may struggle with buttons and zips because we're starting to lose our fine motor coordination skills. They may be able to put on a t-shirt but not a button-up blouse. They may need help in sequencing how to put on the button-up blouse. They will be able to use their hands and be able to manipulate objects, but they may need help in orienting them, or if there's a problem, they may not be able to identify there's a problem and fix it. So usually when I work with my patients, I will let them try. If I see they get stuck, I'll give them a little cue. If they still get stuck, I'll see why they're stuck, and then I'll try to fix that part and let them finish it if I'm able to let them finish it. So if a person's really struggling to tie their shoelaces, I'll give them 2 tries, and then if they haven't done it on the second one, I'll go ahead and help them, because I don't want them to get frustrated. I don't want the person to get so frustrated, but I want them to try, but I don't want them to get frustrated and have a problem. So I try to stop it right before they get frustrated. So you get to learn how to read people very well. You got to look for the non-verbal signs of they're getting frustrated, they're sighing, they're looking like they're rocking. There are lots of signs. People show you all sorts of signs when they're starting to get frustrated. So I will let it go right up to before they get frustrated, and then I'll step in and help them. But I won't just jump in and help a person at the beginning if they did not need my help. They will need always help. Like if you take somebody at a mid-stage or stage 6A to a new location, like to my mom when she came to visit us a few years ago. Actually, this past week here in my house, 2 weeks ago, I think it was, my mom and dad came down for a lunch or something. My daughter was here. And my mom's been in my house numerous times, but my mom has mid to later stages of dementia. She's got middle stage. She's probably about a 6A of dementia. And what was interesting is she's been to the bathroom in this house numerous times. And this last time she came, every single time, and I kid you not, it's a straight shot, hang a left, and you're in the bathroom. It's not hard. And my mom cannot locate the bathroom in my familiar but unfamiliar to her environment. She gets lost in my house. My mom gets lost in my house. So people who are in an unfamiliar environment or unfamiliar to them will start to get lost and need cueing. And you need to show them the whole time. They will need inconsistent help sometimes to go to a familiar environment. So sometimes then even and this will happen to people over time, they may start to get lost in their own home. Right, they may be trying to go to the bathroom and take a wrong turn down the hallway and end up in the bedroom. And then it's like, well, I was going to the bathroom. Where's the bathroom? So people will start to get lost, not consistently at a 6A, but they will start to get lost in their own familiar environment and may need some cueing at home to locate a place that they want to go. They may attempt to walk to a familiar place. They may know where they're going, but they may not find it. They may go lay down on a guest bed instead of laying down on their bed because they see the bed. They walk down the hallway, they see the bed, and they go get in the guest bed because they wanted to lay down, and they're not laying down on their normal bed or their normal place where they will lay down. At this stage, people will still pick things up and use them routinely the way they should, like a pen, a spoon, a glass, normal, familiar things. And I'm going to take a sip. And some leisure activities, but they won't know that there's a purpose necessarily to the activity. So they can do a repetitive thing, but they may not necessarily realize that there's a result. For example, making a card, right? You might be able to get them to sit and color it, but they may not know that that card is supposed to go to their granddaughter for her birthday and that it's her granddaughter's birthday. So another example would be to be able to pick up dice and roll them, but not necessarily know that the game has rules and what those rules are for the game. So these are a lot more of the functional types of applications of the functional assessment staging tool. So I think I love this. This is one of my favorite tools to use. So to 6B, last week we talked about the functional assessment staging tool, and this is the adapted one. So to 6B, they will need help in bathing themselves. They won't be able to adjust water temperatures, which makes them at risk for burning, right? Which is why it's important. We want to make sure that they don't scald themselves when they burn. Don't scald yourself when you burn. Don't burn. So we want to adjust their water temperature. I have a patient right now that I'm working with that when I take her to the restroom, she only opens the hot water faucet. And she doesn't take the soap, and she doesn't sequence herself through her hand washing anymore, but she'll turn the hot water faucet on full blast. It's coming out full blast. I'll throw my hand under to feel the temperature, and then I'll adjust the temperature, because at a stage 6B, people they cannot anticipate that water's hot, and then they don't adjust the water temperature, which puts them very much at risk for burning themselves. They will start to have difficulty getting in and out of the bath, and they may not necessarily sequence themselves all the way through bathing, and then they won't dry themselves off. They won't necessarily dry themselves off adequately, which means you can get a yeast infection and all sorts of other things because of being damp, right? So we want to make sure that people dry off completely. At a stage 6C, they will start to need help with toileting, flushing the toilet, being able to wipe themselves when toileting. This is where we start to need to be quality control, right? When somebody is having trouble with this, we need to make sure from a hygiene perspective that they get cleaned, because otherwise, especially ladies are at a lot higher risk for urinary tract infection, because the distance between the anus and the urethra is smaller, and so if they wipe from the back end to the front end, they take the down and dirties up into their urethra, that goes straight up to the bladder, and then they can get a urinary tract infection. So we want to make sure that at a stage 6C, which is a middle stage, that we are making, that we are aware of the mechanics. And a lot of times people at this stage are already starting to maybe have some bladder incontinence, and people will get a urinary tract infection if they're sitting in a wet brief or a wet pull-up. So we don't want people to sit in a wet brief or a pull-up, because they can get a UTI from that. So the next stage, stage 6D, this is where people typically start to have urinary incontinence in the absence of a urinary tract infection. And this is also one of the stages where, like in my experience, there's a tipping point. There are two things in my experience that I'm not against facilities. I'm not a proponent for just putting everybody in a facility, but my worldview is not everybody should remain at home, and not everybody is safe to remain at home, and every person's life and resources are different, and so we make the best decision each person at a time. But one of the there are two things that typically people end up being in a facility for two reasons. One is incontinence, bladder and bowel incontinence, if families don't feel comfortable in managing incontinence. And the second one is behavior. Any kind of really challenging behavior that a family cannot manage. And then really the third thing is if you need two people. It's really hard. If you need two care providers or care partners or care companions to help somebody, it is very hard to have two people in a home helping someone. Now, earlier on, if you were on earlier on in the program, I talked about my patient that I saw today. Her family is doing a phenomenal job. They always have two people. And if they don't have two people, they can call somebody and somebody can come. And they have committed to keeping mom at home. And they are doing a phenomenal job of doing it. And I will walk over hot coals to help them keep her at home. And then there are other people that I recommend that they go to a facility because they're not getting the adequate care that they need at home, and that they will actually live at a higher quality of life and a higher level of independence in a facility. So there are pros and cons to both. So that was my little soapbox for the evening. So urinary incontinence. When people are starting to have urinary incontinence, one of the best strategies you can try is timed voiding. So what is timed voiding? Timed voiding literally means putting them on a clock and taking them scheduled every 2 hours, every hour and a half. Not, do you need to go to the bathroom? It's time to go to the bathroom. Let's go. Come on, we're going to go to the bathroom. Put them on the toilet, see if they'll go. When we're toilet training our kids, right, what do? We take them to the bathroom every 2 hours. We take them, put them on the potty. Time to go pee. And that's how we get them to start to become aware that they are needing to void, right? Now, people who are going through this in the reverse, we cannot do that, but we can timed void them. And if we take them to the bathroom every 2 hours and just put them on the toilet and see, maybe we can keep them dry in between and they're not as frequently incontinent. So stage 6D, this is where people start to have bowel incontinence without there being any physical reason for it, right? And the frequency, so also frequently toileting may decrease that if you, so one of the things that we do and that I tell people to do all the time is a toileting diary works real well. Even if you only do it for a week, right? Write down literally every single time the person is wet. Every single time they have had a dirty brief. Because all of us are routine. We have a we have a good routine. Like my husband, first thing in the morning, he can go to the bathroom once a day and he's done. Me, I probably have a bowel movement 4 times, 5 times a day. That's always been me. I don't know why. Right? My mom's the same, my sister's the same. So if I know that my routine is that, and if you write it down, if I were to become incontinent and you were to diarize it, you're going to notice between 7 and 7:30, right? Between 9 and 9:30, between 2 and 2:30, whatever. Everybody has a routine. So diarizing a person's bowel incontinence can help you take a look and see if there's a pattern. And if there's a pattern, we can time void it, right? So that can help with managing bowel incontinence at home. They will be able to pick things up and use them like a toothbrush or a pen or a spoon, but they will only be able to use them for a very, very short period of time, 10, 15 seconds. And so these are the people, they can still feed themselves, and this is a functional thing, right? They can still feed themselves, but they may need you to repetitively say, take another bite, take another bite, take a sip, take another bite, or combing your hair, right? Brush your hair, 1, 2 strokes. Okay, keep going, 1, 2 strokes. Okay, keep brushing your hair. 1, 2. How about a little more behind? Okay, so you cue them so they can do it, but they cannot sustain the time needed to do the task because their attention span's not there. But they can still do it. But it's very, very, very short periods of time. Very short. 10, 20 seconds, very short. So now we go into the last 2 stages that are a little bit different from the functional assessment staging tool, and we're really looking here at what are retained abilities, what can people still do, right? So a person in the previous stage, they're a great person to give a washcloth and say, wash your face. Okay, a little more, wash your face, wash your arm. So I'm still giving them things that they can do. I'm not saying take a shower, and all of the sequencing things that they have to do for that. But I will say, all right, wash your arm. Okay, let's wash the other arm. Keep going, a little more. So that's how we get them to still keep their retained abilities. I almost knocked my water over. That would not have been good. You guys would have seen me jump up and run to get a towel. So late stage 7. So this is stage 7. This is where the occupational therapy model starts to change. So people start to have speech that's limited to about 6 words in a day. So very, very limited speech. And they will mostly say things like yes, no, okay, or don't hurt me, or get out of here, or I love you, or I like you, or get away, or no. No is a favorite word, right? People at this stage will start to have very limited walking ability because they're not able to stand up right against gravity by themselves. These are the people that we may do what I call handheld assistance. So I usually have my hand, I'm left-handed, so I use my left hand on their pant leg, not pant leg, the back of their pants, and then I will hold their other hand and I will walk with them. So they can walk. They don't tend, people at this point don't tend to do super well with a walker or a cane or anything. They don't know what to do with it. If they do use a walker or a cane, you are in charge of moving the walker, turning it, direction, anything thinking, you are in charge then of making sure that they're using it in the right way. And so at this stage, at this late stage 7, they will need a lot of assistance with getting dressed, a lot of assistance with bathing, a lot of assistance with toileting. They won't necessarily take something in their hand anymore, but if you say lift up your arm, they'll pull up the, so that you can get them dressed. So we want to make them use their big body movements to be able to help us. Pick up your leg. Let me put your pant leg on. Pick up your other leg. Let me put your pant leg on. So they will need you to do everything, but they'll stand up so you can pull their pants up, or they'll stay standing for you to pull their pants down for them to go toileting. Lift up your arm, I want to wash under your arm. So they can still do things, but they're these big movements. They're not necessarily fine movements and coordination. And these are the people that we do some big games with, right? A balloon toss. Balloon toss is great, guys. Or kicking a ball. Having a person sit in a chair and rolling a ball and having them kick a ball. Those are great things. Or holding onto a parachute and throwing it up, putting a ball in there and lifting it up so that they can see cause and effect. Very big movements, not a lot of fine. And then stage 8, this is where the occupational therapy model differentiates it between a late stage and an end stage. People at an end stage typically should be, in my opinion, on hospice. I don't think we recommend hospice soon enough. Don't be afraid of hospice. Hospice has tremendous services that they can help you with. These people start to have just one word, yes, no. They may still make eye contact with you. They will do very repetitive things like la 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 la. Sometimes you can get them to sing. Singing is a great activity. They won't be able to sit up on the edge of the bed without help. They need some sort of physical help to sit up on the edge of the bed. And they will need entire assistance with all of their basic self-care skills. But here's what we can do. Here's the part that we can still, this is the retained ability at this point, right? We cannot necessarily dress ourselves. We cannot necessarily feed ourselves. But we can still smell. We can still hear. We can still feel. And so that is what we start to do with people at this level. When people are at this level, you bring them in their favorite smells, their lotions. Here, smell. Oh, doesn't this feel good? Let's sing together. What's their favorite song? Hymns. If people grew up in church, hymns are great. Things like Amazing Grace. You'd be amazed. I sing Amazing Grace to a lot of patients. And they'll sing with me because they can hear it and it taps into a memory, and then they're able to participate, even if it's just for a few seconds, right? And so we want to get right in there with them. Taste, smell, touch, all of the sensory things, sight, not on the other side of the room, right here. Right here where they can see. And then the final end stage, this is where people have lost the ability to smile. And they're not able to spontaneously smile. They still make eye contact with you. You got to be super close, but they can still make eye contact with you. And they've lost the ability to hold themselves up against gravity at all. And so holding their head up, like sitting unsupported, like I'm sitting unsupported with my head up, they're not able to do that anymore. So At that point, sensory stimulation is what we try to elicit, and then we're looking for, does it look like they like it? Are they enjoying it, or does it look like they're trying to get away? If they're trying to get away from it, I'm going to stop. I want them to enjoy, I want them to feel love and comfort. And so if I do things that are noxious or unpleasant, and I notice it, I will stop doing it, because I want them to still be able to enjoy and have the best quality of life that they have, even at this level, which is the end stage. So today was just a little bit of a recap of the functional assessment staging tool, but this was the adapted functional assessment staging tool that is more for really looking at what the functions are and how to maintain those functions. And I'm going to keep expounding on this, because this is the stuff I use every single day, and it is super, super practical. Once you've learned it, it is very practical. But I have like 2 minutes left, and Moira, I don't know if Moira is out there tonight or not, but she had a question earlier today. Why do people with early signs of dementia feel uncomfortable meeting people that are further into their journey? And Moira, I really valued that question. I know it must be super hard. I can only put myself in the same position. I think a couple of things come to my mind. Number one, oftentimes people, not everybody, but a lot of people are in significant denial that they have a problem. If they are not in denial and they know that they are having trouble, I think it must be, the stigma out there right now is so super high. And oh my word, I love these sites that we're on, but this is one of the reasons I actually started this group, is because I find that a lot of these large dementia sites are extremely just focused on the negative part of dementia. Yes, it's challenging. Yes, it's complex. I get that. Yes, there are lots of things that are not super ideal. But there is so much we can still do, and so much joy and so much love if we just focus on the retained abilities and not just the bad stuff, right? Not just looking at the bad stuff. So I think that when people know that they have dementia, and they know that they're going through this, because of the common vernacular out in society that there's nothing you can do, I mean, my word, if I was told I have some sort of a cancer, and there's literally nothing I can do to help myself, I'm gonna be down in the dumps. I'm not gonna want to try. I'm not gonna try to maintain my highest level of independence. I'm not going to necessarily do all of this stuff. Well, that's what's out there, that there's nothing that you can do. Well, research is showing that the earlier you start, there are a lot of things that you can do, but it's hard work, and nobody wants to put in the work. Nobody wants to put in the reps. So I think when people have early signs of dementia and they feel uncomfortable meeting people or hearing about other people with dementia, I honestly believe it's because society has done such a terrible, we've put such a stigma on cognitive loss. It is like the thing nobody wants to talk about, right? It's like that elephant in the room. Nobody wants to talk about it. And so I think that when we feel that discomfort that we have when we see someone further on, it's because what goes through our mind is, that's going to be me. I'm going to be just like that. Well, like a lot of people, I've seen them post in the group say, when you've met one person with dementia, you've met one person with dementia. There's commonalities, But every person's dementia looks different because everybody's brain is different. Everybody's brain is different. Everybody's cultural experiences are different. Everybody's education is different. Everybody's natural resources are different. Everybody's different. So one person's dementia may have similarities to someone else's dementia, but doesn't make it the same as someone else's dementia. So we have to remember that. But thank you guys for joining me. I appreciate you being here. I will be back next Thursday. It's Thursday. I appreciate you for being here. Thank you for hanging in there, and I'm sorry I was late. I hate being late. And like I end all of my programs, the Lord bless you and keep you. I really, truly, I hope you guys know this, and I say it from the bottom of my heart. I pray for you guys in this group. I pray for you guys when I know something's going on, and if you need prayer ever, just please reach out and I will say a prayer for you. So the Lord bless you and keep you, and I will see you again next week. Thank you guys. Bye.